live, and over to you, sir.
Thank you. Thank you, doctors, for this joining this program on liquid is solid in NSCLC. And we have Dr. T. Raja as our program director today. I'll take a few minutes before handing it over to Dr. T. Raja. Next slide. So welcome, everybody. I just want to talk about a little bit about Zydus. Zydus is a diversified organization with a focused approach. We have global generic business. We have global branded generic business, specialty product and vaccine and biosimilars. We are the first company to launch ADC TDM1 in India, then Adalimumab, then plasmid DNA vaccine, and second in the world to develop typhoid conjugate vaccine. Then we are into NCE and in NBE. We are the first Indian company to launch Salorgetrazar and received marketing approval in various countries. And we have a range of wellness business, and we have a good partnership with many of the leading players in the world, whether it's Pfizer, Takeda, Bayer, and we are the company. We have filed 25 ANDAs across different countries. Next slide. If we look into Zydus, so we are fueled by innovation. Currently, our play is in generic market, whether it's in India or in US. We are into the vaccine biosimilar. India, we are one of the pioneer where we have 13 approved biosimilar and the world first ADC biosimilar. But future pipeline, what we are looking into orphan disease and specialty portfolio, then different NCE, NBE, and novel anti-drug conjugate developing novel ADC for difficult to treat cancer. That's our future pipeline. So as a company, our vision is to improve accessibility and affordability of novel therapeutics, biologics, and antibody drug conjugate for the world. This is quite a busy slide, but I'll just highlight a few of the points. We are have 70 years of experience with more than $2 billion global revenue. We were the first company to launch the world novel biologic rabies vaccine. And we are among the 14 brands in the top 300. And if you look into the world market, we are the 5th largest in US generic market. And we have around 1,400 research scientists across the globe working for us. And if you look into, we have 650 patent application worldwide. We are the first one to launch the tetravalent influenza vaccine in India, the biosimilars like Adalimumab, and we are working in the different other areas as such. And we have around 21 biosimilars in the pipeline and 6 novel biologics in the pipeline. Next slide. We have around 24,000 employees across the world, across 4 continents. We are the fast growing generic company in US, then operation in France and Spain, strong presence in Brazil and branded generic market. And we are the 4th largest pharma company in India. If we look into our R&D facility, we have a center of excellence. A team of around 1,400 scientists are engaged in drug discovery and development, and they are working on peptides, NCE, formulation development, small molecule biologicals, monoclonal antibody, nutraceutical, wellness product, API research, and controlled substances. Our research is mainly focused in the cutting in research technology in NCE, whether it's in cardio, diabetes, metabolic diseases, inflammation, pain, and definitely in cancer space. If you look into, though this slide doesn't make us very proud, because if you see in the top Indian oncology, only we are there. But we definitely want many of our Indian companies to join our hands in the top 5. But currently, we are the only company in the top 5 Indian oncology company. And other space is being occupied by the multinationals. So what we thought about in Zydus that we have to go beyond the pill to address the patient unique needs. And for that, for ensuring a holistic approach, so we now have come out with diagnostic, medical device, and digital therapeutics so that we strengthen your hand for the patient wellness. For diagnostic, we have joined hand with CanAssist Breast. It's a predictive risk recurrence, a patented test for risk stratification in breast cancer. And definitely Gardant, a leading precision oncology company with a mission to conquer cancer with data. Oncology treatment, if you look into this slide, oncology treatment is becoming more and more complex over the period of time. When we start with 2003 from Jeftenif, when we look into 2004 with Emdentanif, and you'll find that companion diagnostic is very important for the development of the many other molecules which have been shown over here. With this, we definitely want clinical needs NCS report to tailor the most effective treatment plan for their patient, and selection of the right test is pivotal for ensuring the most suitable treatment course. And for this reason, Zydus has joined hand with Gardant to provide a solution of best suitable treatment for your patients. With this, I invite Serene Chin, Senior Director Marketing, Asia, Middle East, Africa, and EMA Market, for the next presentation on Gardant.
Thanks, Ali. Yeah. Hi. So at Gardant, our mission is actually to conquer cancer with data. So maybe I can move on to the next slide, please. So how do we actually conquer cancer with data? We want to transform patient lives across the continuum of cancer care. Gardant, when we first started, our first flagship product, Gardant 360, which is also the first FDA-approved CGP liquid biopsy for solid tumors, has been our flagship product and has been well accepted now after launching for 10 years. So after Gardant 360, we then start to launch our few other range of products, including TissueNext and Gardant 360 Response as well, all in the area of therapy selection. Recently, just last year, we actually launched a new product called Gardant Reveal, and that is in the space of the early cancer, in colorectal cancer space. So for example, if patients have undergone surgery, they would be keen to know that, okay, would my cancer come back? So Gardant Reveal will actually provide the answer to see if adjuvant chemotherapy is actually needed, or in terms of monitoring treatment for the patients subsequently as well. And very excited, this year we just launched a new product called Shield, and that is even the earlier part of the disease, which is actually for screening. We have actually submitted to the FDA. We have this discussion with the FDA end of May, and really looking forward to get the approval for Shield as well. So I'm happy to say that, in the region, Gardant is the only company that has products across the continuum of cancer care. That is in therapy selection, early stage, minimal residual disease, as well as screening. And being the pioneer in liquid biopsy, we now have about 700,000 patients who have actually benefited from Gardant 360. And from the company's perspective, we have actually worked with a lot of hospitals across the regions in terms of clinical studies, and to actually publish more than 500 peer-reviewed publications now. So this is by far one of the largest for the liquid biopsy space. Next, please. So therapy selection utilization will continue to grow. And we also see that in terms of clinical practice, there's actually much more acceptance of liquid biopsy. Usage could be in a form of combination, including the use of liquid plus tissue. Or we have also known that, a lot of pharmaceutical companies are now coming out with new biomarkers, and there are more FDA-approved therapies as well for biomarkers. So this is an area where a lot of clinicians or physicians will feel that there is actually a need for liquid biopsy. And lastly, physicians are actually using CGP testing in earlier lines. We first started in progressive settings, but we can see that actually now there is a change in a paradigm where instead of just progression, a lot of physicians are using it on newly diagnosed patients as well. And I think what really shows as evidence is also there is an increase in clinical guidelines. NCCN, ESLAC guidelines, and ESMO guidelines have actually recommended the use of liquid biopsy. And just this year, NCCN lung cancer guidelines actually include concurrent testing with both liquid and tissue biopsy to maximize the sensitivity and as well as the speed to results, because we all know that liquid biopsy, the turnaround time is actually much faster. And I think for Gardant, our selling advantage is always, the fast turnaround time as well. So therapy selection in terms of, liquid biopsy will definitely be growing in that space. Okay, thanks. Over to you, Ali.
Yeah, thank you, Sareen. The objective for this meeting with all the advisors who are here, we want to understand importance of analytical and clinically validated test. Is liquid first approach our future? Can concurrent tissues and liquid testing be considered as a gold standard? Role of liquid biopsy in response monitoring, selection criteria in broad panel NCG test, and liquid versus tissue biopsy at progress. So we want to learn, that is our objective. We want to learn from all the advisors. And now I'd like to hand over the platform to Dr. Raja, who is the Director of Medical Oncology at Apollo Hospital, Chennai. Though Dr. Raja doesn't require any introduction, but it's my humble duty to introduce Sir. Has many years of experience as a medical oncologist. Dr. T. Raja has a proven track record of dealing all sort of cancer patients. His expertise and insight on cancer treatment make him one of the top oncologists in the country. Along with a successful career as an oncologist, Dr. T. Raja has actively participated in many international conferences, and he has published many numerous papers in oncology in both internationally recognized journals. Dr. T. Raja continues to be a regular follower of the latest advancement in the field of medical oncology. With this, sir, I invite you to take set the context and take the program forward, sir. Thank you, sir.
Thank you so much for your kind invitation, and I thank both Zydus and Gardant for this generous invitation for me to set the context for this beautiful meeting. I hope that you are able to see my slides and I'm audible.
Yes, sir.
Okay. Yeah. Thank you. And it's a pleasant duty here. And we are going to really listen to eminent speakers today. It's my humble duty to just set the context. As we have all known, lung cancer has moved from morphological diagnosis to molecular diagnosis, and we know that every few months we understand that one more mutation can be possibly targeted. So the list is ever growing. But the trouble with lung biopsy samples are that by the time they run through the mandatory immunohistochemistry and then come down, finally we end up having insufficient tissue. So tissue is always the issue, as has always been said. And by the time we come to molecular testing, there is very little tissue. Not only that, we also look at how do we monitor the patients over a period of time. So there comes the real impact of liquid biopsies. Liquid biopsy can be a substitute for solid biopsies. It can be used, as was mentioned by Ms. Shireen. It can be used at the diagnosis as a sequential approach, or as a plasma first approach, or complementary to a solid biopsy. Now, there is no doubt that there are a number of clinical experiences, well-published article that has already proven that liquid biopsy is as good as a tissue biopsy in determining the frontline therapy. Sometimes we even think that liquid biopsy have some superiority. So, we clearly understand that the versatility of liquid biopsy comes from the fact that we can enumerate and study the circulating tumor cells, and we can look at the circulating tumor DNA, and we can look at the ctRNA, and we also can look at exosomes. So this really improves our chance of identifying many things about the tumor. The technology about the liquid biopsy is also really proliferating at a rapid speed. If you look at what can be done with ctDNA or with the CTC, now you have what we call beaming power. And if you want to look at the CTCs, you have the cell search systems. And if you want to look at the exosomes again, there are a lot of magnetopores, and eminent technologies have come in. That's really revolutionizing the liquid biopsy, and that's going to also call for something called what is the standardization of all these technology, and every day the technology seems to be improving. Not only that, It is also now becoming versatile that many sorts of liquids can be tested. That includes saliva, urine, and stool and sputum, apart from the blood. So that makes it very, very exciting. Now you can look at a whole lot of things that's happening in the tumor, around the tumor. That gives a real dynamic view of what's happening. And it's not only used at the time of diagnosis, but it's well established that longitudinal monitoring is also one of the necessities, and that's where liquid biopsy again makes a huge impact. Not only that, as was just mentioned just now briefly, it's really moving very fast into the early stage setting, and it's moving into early detection of any stage, and also in the stage of screening of lung cancer. And these are some of the important studies that are ongoing. I've just put them here just for the sample that, Discover and Grail and Thrive. These are all liquid biopsies in the early detection setting in lung cancer, just to give you a flavor of what's happening. And we are going to listen to eminent speakers today. The first one is going to be Dr. Bhuvan. Bhuvan is my dear colleague. He's from Gurugram. He's going to speak on the Indian perspective on the landscape of genomic diagnosis in lung cancer. After that, we have Professor Sanjay Popat, and he's going to speak on the topic of the day: liquid is solid in lung cancer. And then thereafter, we are going to listen to eminent moderation by another of my dear friend, Dr. Nitesh, and look at the names of the panelists. They are all literally the best in the field at this point. The best team that you can assemble in the parlance of cricket. These are all heavy hitters, and we are excited to listen to all of them. Dr. Bhuvan, so you are starting the opening bat. Over to you, Dr. Bhuvan.
Thank you, sir. I'll just put my slides up. Yeah, so thank you, Zydus, and thank you, Gardant, for this opportunity, and thank you, Dr. Raja, for inviting me. Anyway, so as for the Indian perspective, I in Saket OPD had a patient who came from Saket, who came from AIMS. The biopsy was done in Gangaram. It was a deep tissue in the lung. A 57-year-old male, chronic smoker with a bad FEV1, and during the biopsy, he had a pneumo which required an ICD placement, and they could get some tissue out of it, which was submitted to AIMS for doing an IHC. It's a non-small cell TTF1 positive adeno. They had run ALK, ROS, and EGFR sequentially. So ALK is negative, ROS is negative. The EGFR has come out to be indeterminate because the tissue is insufficient. And I think that's possibly the story right now, that most of us who go with the sequential testing, we end up consuming the tissue. And I had no answer today because, well, the tissue is insufficient. Repeating a biopsy is a challenge. It's a deeper tissue. It's a deeper biopsy with somebody who has already had a pneumo the last time when they did a biopsy and required an ICD placement. The cost of it, the morbidity of it, the risk of it is far too much, considering that the patient also, by the way, had an ejection fraction of around 35-40%. So I think that's where the role of liquid biopsy comes in. I think that's the ideal case where you will definitely require the bloods to be drawn and for the nice study data to be picked out and to be conveyed to the patient that we are pretty safe once we do a liquid biopsy. And I think I'll dwell straight away into the Indian perspective. I think the initial few slides were more of the demographic, which I think the audience which we have today really don't need any information on that. They are either the authors for the articles which they have written, and I think we're pretty safe in going straight away into the understanding that we have a lot of driver mutations. We rather have started dividing the non-small into oncogene addicted and non-addicted, and I don't think we name the genes anymore. Initially, I think when we all started, we used to name 3 genes and then 4 genes and then 10 genes, and now I think we have simply said that it's a oncogen addicted versus non-addicted, and that's where we leave it. Moving forward, we have a repository in which the respondents from India were asked, and it was seen that the response in this survey was primarily from the corporate private hospitals with the postgraduate degree, and as well as from the government. So basically, it says that the patients with lung cancer usually go to the bigger hospitals. That's where most of them, they end up showing themselves, and that's where the decision making at these centers also, it's pretty heterogeneous. We have not reached a homogeneity there. Patients, or rather as individuals, as doctors, we ourselves have not been able to define what we should be doing. If you look at the pyramid chart there is a majority of us in the Indian scenario, we end up sending a EGFR ALK simultaneous testing, and then there is a sequential testing of EGFR ALK. Only 14% of the patients or the respondents undertook upfront NGS, and none, and EGFR only was 7%, which is really not the thing. But what is rather surprising to me is that it still says that almost, or one in 10 or 1.5 in 10 end up doing an NGS for a lung panel, in which, if you look at the number of genes, I don't think we'll ever be able to utilize the tissue. And I think it's rather important that we understand the need of a CGP to begin with, and rather pick up the tissue and do a CGP, then go about doing a sequential testing. Also, what has been seen is that majority of us, the practice we have, and the kind of medicine structure we have in India, where most of the treatment is self-funded or it's funded by the third parties and the government is not paying much. We tend to start the therapy before we get the genomics report. However, most of us do shift the patient to some kind of targeted therapy once we get it. And I think the practice has gradually changed from putting it as a maintenance to now stopping the chemotherapy altogether once we have a known mutation. And but then it also clearly says that most of us do end up starting the therapy, and it's, mind you, I don't think the Indian subset of patients, 70% of them do require a therapy to begin with. I'm sure the number of patients who we can't wait will be significantly smaller, but then yes, there is a start of the therapy does tend to happen before the genomic reports come in. As far as the genomic data is concerned, I think we are kind of into the world percentages. What is good part is with the Gardant being there, the TAT is usually less than 7 days. The ctDNA has been detected in almost 94% of the patients. The EGFR remains to be the most common. Then there is a ERBB2 amplification or mutation, which has not been mentioned, but I take it that it will probably be amplification more than the mutations. Then there is KRAS, MET, ALK, ROS, and RET. So these are the most common mutations which are found there. We also understand that the drugs for it are usually available, and if they're not available, I think most of them have by this year end, we'll have most of them there. I think AstraZeneca and Roche, they do tend to bring, they are planning to bring pralsetinib, the RET inhibitors there. And MET, I think we have, ERBB2 we obviously have, ALK we have, EGFR we have, I think NTRK we do not have, and I think they also need to come in. So most of the drugs we do have availability for, and I don't think there is any reason that we should not be doing comprehensive CGP to begin with. Why should we be doing that? Because there's a clear survival advantage, and we are all sitting on that data for which we have understood that there's a clear survival advantage of doing a targeted therapy rather than a cytotoxic chemotherapy. And the response rates are better, as well as the survivals are better. And I think it's also part of the guidelines, be it squamous or adeno significantly more than squamous, but we do understand that most of the guidelines do suggest that we do a genomic testing, rather a comprehensive genomic, before we do it. And so is the mandate out of the consensus guidelines. I think we have all been through the consensus guidelines, and we all understand that the tissue is the first option. And if you have tissue, it obviously gives you the flexibility or the privilege to do the PD-L1 testing also, which in a smoker becomes very important. Well, if you don't have a tissue, ctDNA is the second best option there. And I think we have good correlative studies. We have good real world studies in which there is a good correlation between the liquid and the solid. And I think we are able to comprehensively tell ourselves that there is no need to do a biopsy. If it's a difficult biopsy, I think the blood will be good enough. I think again, the expert consensus has told that if you don't have a tissue, preferably tissue, but if you don't have a tissue, I think ctDNA is a good enough material. So this is where the guidelines are, that you can either test for EGFR, ALK, ROS, and PD-L1 if there is no driver detection. If you feel that the patient is a non-smoker, you should definitely go for a CGP. If you think the patient is a smoker, you can treat it as a oncogen non-irritated cancer. But I think I am more on the right side, in which I generally tend to do a CGP with a PD-L1, and in one shot understand whether it's a driver or non-driver, and then possibly able to take a better decision. So we have the therapies available. I don't think there is any reason we should not be doing it. I think for the sake of not repeating myself, as for the cost is concerned, I think we're pretty much there. The cost of a test is significantly cheaper than the cost of the drugs which are available. And I think there is, again, as per the finances are concerned, that's also not a reason that you should not be doing it. And I think I'll possibly end it here. So I'll let Dr. Poppert go on with his talk. And Dr. Raja, would you want to invite him or?
Thank you, Dr. Bhuvan. I think you clearly summarized where we are at this point. I think we are in a much better shape than the last decade. That's what you kind of. And Professor Sanjay Popat, it's always a pleasure to listen to you. We have been privileged to be guided by you and educated by you in many forums, and we have also had the privilege to host you in some of our meetings. Once again, it is absolute pleasure to listen to you. So we request you to take over this topic. Why liquid would replace the solid or as good as solid in the current context in the non-small cell lung cancer? Please, Professor, go ahead.
Great, thank you very much, colleagues. Great pleasure to be here. It's a shame I can't be with you face to face, but nonetheless, wonderful to join you over the internet. I'm just going to share my screen so you can see my slides. So I'm going to talk to you about liquid biopsy, particularly ctDNA. These are my disclosures. Now, when it comes to biomarkers in lung cancer, I think we've said before, we have to make a molecular diagnosis, and that is absolutely key for what we're doing now. You can see that really we need to look at least 10 different genetic sites if you count EGFR as 2. But really, I think the message is we have multiple drugs. We have multiple drugs available, and these days I don't think you can treat at least metastatic, and I would even argue early lung cancer.
Nishant, Professor's slide is not on the screen. Can you please help it out, please, Professor?
Pause.
So you can click on share screen and the slides will be visible. You just share your screen, sir.
Okay, let me just share my screen.
There will be a green button.
Yeah. All right, let me, this computer is not.
Can anybody from the team project the slide? If anybody is having?
Should I share screen?
Yeah, I think.
Dr. Nisarg, if you can share the screen. Hope my slide is visible.
Yeah, now it's visible. Dr. Sanjay, can you see the slides now?
Yes, we are able to see the slides,
Yeah,
and Nishant, you're keep moving as Professor speaks.
Yes.
Thank
you. Yes.
Okay, I'm back.
Commands, yeah.
Thank you very much. Hopefully you got my slides there. Thank you very much. Do I have control of the slides?
Dr. Nisag is
Can we give
handling.
Dr. Popa the control of the slides?
Pranshu,
Sure,
can
sir.
you
1 second. Yes, sir.
please give the control?
Yes.
Right. Okay. So really, as I was saying, these days, in advanced non-small cell lung cancer, and I would actually argue in early lung cancer, you cannot really treat it unless you have a molecular diagnosis. And you know, whether you're looking at 10 genes, 9 genes, 11 genes, whichever way you want to slice it up, really comprehensive molecular analysis is actually fundamentally critical to how we treat lung cancer today. Can I have the next slide, please? So this is the process of how we diagnose metastatic lung cancer in most of Europe. Now, the front bit is probably slightly different in India, but the principle is the same. The patient presents, they end up with a diagnostic consultant, diagnostic expert. The staging then takes place, some tissue sampling takes place, the pathologist confirms it's lung cancer. There's some sort of peer review of that case. Some predictive biomarkers then happen, and then the systemic therapy starts. Next slide. Now, the molecular analysis, I'm just going to talk you through the different types of molecular analysis. So imagine this is a gene sequence, and imagine that each word here is the exon within a set of genes. What a lot of people are doing is relying on PCR-based tests, and I can entirely appreciate that in India, at least, EGFR is so prevalent that it makes sense to look for EGFR mutations up front. But this is challenges. Next slide, please. So imagine that you can see in red, I have got a single nucleotide change, a mutation. How do you spot that? Next slide. Now, what happens is that mostly PCR-based tests are being used to find that mutation. And PCR-based tests, whilst they're cheap and they're efficient, the problem is that they only look for specific mutations in specific genes. And the analogy here is looking for specific spelling mistakes in specific words. So if you happen to be looking for a spelling mistake in the DNA word, you will find this particular spelling mistake, i.e., if you're looking for a particular mutation and it happens to be there, you'll find it. Next slide. Now, what happens if your mutation is in a gene or a region where your PCR test is not looking? Your PCR test will come back as negative, and you'll interpret that as wild type, when in fact there's a mutation there. You can see in the blue box there's a spelling mistake, and your PCR-based test has not picked it up. So that's called a false negative. Next slide. So this is really why we need NGS. NGS isn't looking for specific spelling mistakes. It's reading the entire paragraph or all of the sequence within the DNA, or in short segments, to tell you where the errors are. So it's not reliant on particular knowledge beforehand to test particular areas. Next slide. So the common PCR-based tests that are often used are EDILA or COBAS. These are very quick, often quite cheap, and they'll tell you the PCR-based result quite quickly. And many labs also have in-house DDR PCR-based tests. It's the same thing. So they really very much look at a set sequence of DNA mutations, and if your mutations are there, very good, it will spot them, but if they're not there, it won't find them. Next slide. Now, let me give you an example of exactly why this is important. This is a 63-year-old Asian patient, actually South Indian patient, came to our practice, T3N3M1C, metastatic adenocarcinoma on biopsy, ex-smoker, immunohistochemistry was negative for ALK-ROS, PD-L1 1 to 49%. And the local laboratory performed a EDILA test, and it showed no mutation detected. So the local oncologist said, well, you know, you're not very well, ECOG performance status 3, really we're looking at best supportive care in this scenario. That's why they came to us. Next slide. We performed a ctDNA NGS with Gardant and actually identified an exon 19 deletion. This particular exon 19 deletion is not within the panel of IDILA. So in fact, the interpretation of the IDILA test is not that it's EGFR wild type, it's that it doesn't have the set sequence of mutations that the IDILA test is designed to pick up. So really, this patient is EGFR exon 19 deletion positive. We started the patient on osimertinib, and the patient had over a year of excellent quality of life before relapse. Next slide. Now, we've got a bigger problem because we now have exon 20 insertions which are now druggable first line with chemotherapy and amivantamab as a licensed treatment coming through. If you look at most of the PCR-based kits on whether your exon 20 insertions will be picked up, the answer is no. In this particular diagram, you see a schematic of exon 20, and in blue are all the different exon 20 insertions that have been picked up by NGS and are druggable. And in orange are those which are picked up by PCR-based tests. So if your test is going to use PCR-based technique to find an exon 20 insertion, you might as well pack up and go home because you're never going to find them. Those patients are going to be treated with chemotherapy by itself or chemotherapy with immunotherapy, even worse, I would suggest, because you're going to have the expensive immunotherapy and all the adverse reactions that we find. Where my orange slide is looking at the 763, 764 FQEA genotype, very rare, very, very rare. But this genotype within the C helix is very sensitive to even gefitinib. You don't even need osimertinib. Very sensitive to gefitinib. You will never find it unless you're doing NGS because it's not even on the PCR-based panel test from the commercial PCR labs. So you really must have NGS as your routine go-to technology. Next slide. Now, the problem that we have is even if you want to use PCR because you think, well, my patient can't afford this, we've got false positives with COBAS. So these are two independent data sets. The one on the left is from Japan and the one on the right is from Korea. You can see in the one in the left, patients 4, 5, and 6, exon 20 positive by COBAS, completely negative by Oncomine. In the right-hand panel, patients 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, and 20 all have exon 20 insertions by COBAS. All are negative by liquid NGS using a variety of providers. And in fact, this has been flagged by the manufacturer. So the problem that you've got is even if you're using a PCR-based ctDNA or a PCR-based ddPCR or a qPCR-based test for your frontline detection or for EGFR, you will overcall and you'll have false positives in exon 20, which is a total disaster as well. So you really do need NGS to try and nail this completely. Next slide. So I would suggest in the modern era, TKI alone is only suitable for a group of patients. You want to know about the poorer adverse risk factors such as TP53 and RB1. Because if you've got TP53 and RB1, those patients will do even worse with TKI. And you want to be thinking about TKI plus chemo or TKI plus amivantamab. And there's some data coming out at ASCO in about a month's time, which will help you decide. So does your NGS panel have TP53 and RB1? Well, if you're using a common NGS panel such as Oncomine, it doesn't even have RB1 on it. So you've got to think about the coverage of your NGS-based assay. Many NGS-based assays are telling you about whether you've got a drug target available on your NGS or not. And they're not telling you about the comprehensive biology of your tumor. So I would suggest if you're going to use NGS, you've got to use NGS, which tells you the biology of the tumor and the drug targets and whether you need to intensify your treatment or not intensify it. And if your patient's not EGFR mutant, we may argue to use STK11 LKB1 to decide whether you use CTLA4 inhibition in a patient with KRAS mutant disease or not. So use NGS, but make sure that your NGS has adequate coverage for what you're really looking for, which is not necessarily just your drug drivers, but your background genomic architecture as well. Next slide, please. So tissue NGS, you may argue, is a gold standard, and we've heard from our previous speakers that it is, right? But it is a problem. Next slide. So in the UK, we ran a national trial called the National Lung Matrix Trial. Everybody had tissue NGS, and they went into biomarker-directed studies. So we started with just over 6,700 patients going into the NGS pipeline. Of those patients, only 80% had any form of NGS result. But when you look into it deeper, look at the green line on the right. This is using the TST-170 NGS panel, one of the industry standards for tissue NGS testing. Less than 60% of patients had a full 28 gene in this particular data set, full 28 gene based coverage of a result. So even if you're using tissue NGS, many of your patients are going to have tissue failure after you wait for tissue NGS to come through. Real problem in the clinic. Next slide. One of the things we've got to be mindful of is what is the quality of the tissue we're asking our pathologists to send to the molecular lab. You know, when you've got a tumor in a lung and you put a needle biopsy in that, what's the biggest thing that you're going to get? You're going to get air. So essentially, you're not going to get a huge amount of tumor tissue in there. That's why tissue NGS for lung cancer is problematic. And the amount of tumor tissue, as the amount of tumor tissue goes lower and lower and lower, your risk of false negatives or inadequate genotyping goes higher. This is one of several studies which basically says that once you're getting to less than 5% tumor within your actual specimen, then your risk of false negatives goes much higher and statistically significant. But how are you going to know that as an oncologist? Because you're just going to say, right, this is adenocarcinoma. Do any of you really pick up the phone and say to your pathologist, can you make sure that a tumor specimen more than 10% goes for genotyping? Or do you just rely on the pathologist to send the best specimen off? How do you know that the pathologist is not sending a specimen less than 10% or 5% off for genotyping? Because if all you're going to get back is wild type, all you've done is just sequence the fibroblasts in the tumor. So it massively increases your risk of false negatives. So tissue NGS has a lot of issues. Next slide. The other issue is quality assurance. What is the quality assurance of your lab, right? Are you really sure that they are doing the genotyping according to externally validated methods? So back in the day, this is back in 2012, actually, we did a European quality assurance scheme in just simple, straightforward EGFR testing. So we sent around tumor specimens to 20 different labs to see could they actually identify a panel of different EGFR mutations. And in the red panel on the right-hand side, you can see that nearly 1 in 5 got it wrong. So this is just for one single gene, right? When you're going to be doing something more complex by NGS, does your lab participate in the external quality assurance scheme? Have you seen the results of that external quality assurance scheme? Because if that's the lab you're using all the time, you want to make sure that they do participate in EQA and you know what the metrics for EQA are. Next slide. Things become even more problematic when we're talking about NGS. So this is a international external quality assurance scheme data on TMB reads. So using the Foundation Medicine gold standard, this EQA scheme sent 5 different TMB samples to 24 different labs. And the gold standard is the TMB on the right-hand side in the red box. You can see that the gold standard ranged from 5 to 69. But each of the TMB that dots plots are the different range of TMB reported by each different lab. Look at TMB5, the series of dots on the right-hand side. The gold standard is meant to be 69, right? We've got some labs calling 85. We've got one lab calling it at 15. What is the truth, right? You've got to understand that when it comes to TMB coverage and how you define what is TMB is really very different across labs. So please make sure that you understand the quality assurance metrics of your lab when you're interpreting the tissue NGS. Next slide. So people often say, and this is quite correct, that it's very hard to find fusions on DNA, and really you need RNA sequencing as well. That's absolutely true. And this is data from Memorial Sloan Kettering saying if you didn't have any fusions identified on DNA testing and identified and then sent to RNA panel testing, identified RNA fusions in 14% of the specimens. That's very true. But is that really the case in the real world? Next slide. RNA panel testing is really, really problematic because it's very, very much dependent on your fixation. So in our laboratory, we started RNA panel testing and we have resection specimens and biopsies. This is our pathologist, Andrew Nicholson at Brompton. And we were finding that 56% of our RNA tests were failing. So we actually identified that this was due to overfixation. And so what they did is they implemented a change where instead of the resection sitting in formalin over the weekend, one of the lab techs comes in on a Saturday, takes it out of formalin and starts the processing. That reduced the overall fixation, that reduced the overall RNA failure from 56 down to 13%. And the resection failures from 56% down to 6%. And when we have the 13% failures, it's not because of fixation issues, it's because you haven't got adequate tumor within your EBUS specimen to actually genotype. So not only is tissue genotyping contingent on the amount of tumor, but it's also contingent on the fixation. That is a performance of pathology lab. So to really get this all right, you've got to have so many things in, it's like the stars all aligning at the same time. It's very difficult to get this all completely correct. Next slide. So ctDNA, we do use ctDNA. We use it all the time. When can we and how can we use it? Next slide. So we're using ctDNA all the time. We know that it's contingent on the amount of tumor that you have. These are old data from 2014. The volume of plasma-free DNA you detect is contingent on the volume of tumor. The greater the stage, the more ctDNA you detect, which means that if you've got sanctuary sites like CNS-only disease, you're not going to find much ctDNA. If you've got small volume pleural disease, you're not going to find much ctDNA. If you've got tiny pockets of consolidation, invasive mucinous adenocarcinoma, you're not going to find much ctDNA. Next slide. It's also dependent on the proliferation rate. So these are data from the TracerX. I won't take you through them, but basically what it says is the amount of ctDNA identified correlates with the proliferation rate of the tumor. And you've got to have at least 10 cubic millimeters of tumor to identify ctDNA. You can have smaller, but it has to be more proliferative. So the more proliferative your tumor, the more likely you're going to pick up ctDNA. Next slide. The other thing you've got to be careful about is when we detect ctDNA, it's really circulating free DNA. The companies are telling us it's derived from the tumor, but they don't necessarily know. So when you are analyzing the ctDNA, you've got to understand, is your circulating free DNA variant that you've identified from the tumor? Well, usually is, but could it be from the germline? So it might be, and you're looking for a VAF of around 50%. Or is it coming from the leukocytes? So low-level variants, maybe chip variants coming from the leukocyte. You've got to remember, our patients are living longer, right? We've got patients with prostate cancer, patients with breast cancer that are developing lung cancer, right? Are you getting a variant that's not from the lung cancer, but actually is from their low-grade breast cancer? So, you know, if you find particular variants, you've got to think, is this coming from the prostate cancer or the breast cancer? Or is it coming from benign tissue? Can you explain it from other reasons? So circulating free DNA can be quite complex to interpret as well. Next slide. So we're using ctDNA, we're using it all the time. You guys have been using it all the time for gefitinib failure, right? These are the old data from the AURA trial when we were trying to look for osimertinib sensitivity. We know that ctDNA positivity is what we use to identify T790M. And we know that if it's negative in T790M, we want to do tissue biopsy. So can we take that learning from post-gefitinib and move it to the frontline setting for target identification at the point of diagnosis? Next slide. So we know very well that ctDNA correlates very well with tissue. There's very good overlap. But like I said before, there are areas where you have tumor on the left-hand side, which is tissue positive, but ctDNA negative. It's just not shedding it into the blood. And we have areas on the right-hand side, which is ctDNA positive, but tumor negative. That's either for heterogeneity or for real practical reasons. You're not picking it up because of all the artifacts that we've talked about using your tissue genotyping methodology. Next slide. So one of the things we've got to remember is that if you do detect ctDNA, it's a poorer prognostic finding. So these are data from all of osimertinib usage for progression-free survival in the entire AURA3 and FLORA program from AstraZeneca. And what it looks at is the progression-free survival for EGFR mutations detected either by plasma or not detected by plasma. And if you have the EGFR mutation not detected by plasma on the blue, those patients are doing 52% better with osimertinib than ctDNA detected EGFR mutations. So ctDNA detection is both a boon, you found your target, but it's also a hindrance because it weighs you down because you know that patient has a poorer prognostic outcome compared to if they hadn't found any ctDNA. Next slide. So how do we integrate ctDNA into routine clinical care? Next slide. So you're using it for resistance mechanism identification already. Next slide. So we want to be using it now for drug target identification at the time of presentation. Next slide. So lessons we've learned. So if you find your tier 1 genetic alteration, your EGFR, your ALK, your ROS, your MET14 in ctDNA, it's real. You can action it. But if you don't find it, it doesn't mean it's not there. It could be a false negative, and that's especially for fusions because fusions are difficult to detect with ctDNA. But it's really hard to make an assumption that the ctDNA read you've got is wild type. I would suggest that's for expert centers only because the risk of false negatives can be quite high. Next slide. So the common area that you're using it in, the patient's been worked up, they've had their tissue sampling, the pathologist called you to tell you it's adenocarcinoma, and you may want to send it down the tissue pathway, but you may be wanting to use it in parallel. I would argue that you should be using ctDNA as the liquid first strategy. Next slide. We did an evaluation. We did a study where we genotyped 200 patients, both by NGS and Gardant 360 at the time of pathological diagnosis. And our results identified that ctDNA by Gardant, we got the results back in 8 days, right? Very, very quick. And tissue NGS, 22 days. So ctDNA improves the time to genomic information by 63%. But that's really important because actually it massively improves by 54% the time to start on treatment. And actually, if you're going to be starting with chemotherapy, which I think is a complete waste of time in your patients, why are you starting with chemotherapy, which is just going to completely change the biology of your tumor, going to be of expense when you can turn around a ctDNA within 8 days? I would argue just go through the ctDNA blood first strategy whilst you might want to be waiting for the result. Get your patient on the targeted therapy, given that you've got very high targeted therapy rates in India. Next slide. So what did we find when we compare ctDNA to NGS? 25% of cases were negative for ctDNA but positive for tissue, and 25% of cases were negative for tissue but positive for ctDNA. And overall, if you're using both together, it massively increases the yield of your druggable first-line variants by 46%. So if you can afford it, I would do both every time, without doubt, with liquid first. Next slide. Now, here's a few examples. This is a patient that came to see us. We tissue genotyped them, tissue NGS. patient had EGFR exon 20. In the bottom, the lab says, well, it's detected, but the tumor VAF is only 5%. Patient wanted a second opinion, went to see another oncologist. Other oncologist said, well, I'm not sure about that. It's only 5%. You need a liquid biopsy. And I said, this is complete madness. Why do you need a liquid biopsy? You found the TIA1 variant by tissue NGS. So patient paid out of pocket, had a ctDNA. Next slide. What does the ctDNA show? It just confirms the EGFR exon 20 present. So what's happened? Patient has wasted 3 weeks getting all of that organized together with the cost of ctDNA. So if you find a tier 1 variant on NGS, it is druggable, whether it's ctDNA or tissue, you can act on it. Next slide. Here's an example. Here's a patient that has stage 4 lung cancer, minimal, ex-smoker, is known to be EGFR wild type, metastatic disease. Patient had a Gardant 360 and no reportable somatic alterations were identified. So the report from the local oncologist says there are no obvious genetic markers. Patient is teed up for chemo with immunotherapy. That's not the correct interpretation. The correct interpretation is that's a non-informative result. You've got to have tissue NGS to understand what the biology of the tumor is. Next slide. This is a patient, another patient, 52-year-old smoker, T3N2M1A. This has come through our diagnostic paradigm. So we've got a pathway where patients have a ctDNA at time of diagnosis, and they have blood draw first, even before they've had their tissue sample. This is the way I think we're going. This patient came to our Genomic Advisory Board, which I chair, had a ERBB2 pathogenic mutation at 28% VAF, BRCA1 mutation at 50% VAF, TP53 missense mutation 41% VAF. What's the interpretation? Next slide. So the interpretation is that this is a pathogenic ERBB2 mutation and a probable BRCA2 germline mutation, may have a germline TP53 mutation. It's unlikely to have both. We germline tested the patient, shown to be a germline BRCA2 mutation, somatic TP53 mutation. Patient went on first-line chemotherapy and is going to be suitable for HER2 targeted therapy on relapse with background BRCA1 mutation. Next slide. This is a patient, 72-year-old never smoker, T3N3M1B, has ctDNA, comes back with a MAPK1 variant, very low level, 0.36. So what do you do in that scenario? How do you interpret? Do you put the patient straight on chemoimmunotherapy? This is wild type for EGFR, ALK, ROS, RET, everything. No, next slide. This is a case which is non-informative. You cannot be confident that this is in fact an informative result. You've got to wait for the tissue. Tissue, in fact, confirms a EZR ROS1 fusion. Patient should be treated as for a ROS1 fusion. Next slide. What about this case? This is a 87-year-old male, T3N2M1B, presents with widespread disease, bulky thoracic disease, liver metastases. ctDNA demonstrates TP53 mutation, VAF 66%, RB1 mutation 62%. How do you interpret that? So we know, interpreting that if there was an EGFR mutation, look at VAFs, all those, you'd have likely identified it. And this variant frequency is very high. So it's either going to be germline or it's going to be somatic. So RB1 and TP53, you're not going to have both germlines together, so it's going to be somatic. So this tells me this patient likely has a neuroendocrine carcinoma, because that's what you see in neuroendocrine carcinomas. And indeed, next slide, patient was confirmed to have small cell lung cancer. So this tells you these are not germline variants, these are somatic variants at very high level, high proliferation index, heavy tumor burden, entirely consistent with small cell lung cancer. Next slide. So I'm going to close there and say genomic testing tumor is absolutely critical to drug selection. I don't think these days you can treat lung cancer without a genomic diagnosis. We've got to be aware of false negatives and false positives with tissue genotyping, especially with PCR. And ctDNA, I think, is really critical. If you've got a tier 1 variant, you can action it. Blood first, I think, is the way forward. In the UK, we are actually moving forward to ctDNA at time of respiratory presentation, even before they've had their diagnosis. And perhaps next time I can tell you about that. So I'll hand over to my colleagues, and thank you for your attention.
Thank you, Professor Poppet, and it was an amazing lecture. Clears quite a bit of cobwebs, whatever we had about some of the nuances. Amazing to see how everything can be a slippery slope if you just refuse to see it. So pitfalls, but that's real, practical tips, studded lecture. Thank you so much. So I will now invite my dear colleague, Dr. Nitesh, to go ahead with the moderation. And Nitesh, you have a long list of panelists. So I request you to go ahead and invite them. I mean, each one of them are
Thank you.
Friends and very, very eminent oncologists across the country. Nitesh, over to you.
Gosh, thank you very much, Dr. Raja, Zydus, Gardant. It is going to be impossible to follow Prof. Poppert's lecture. And Sanjay, it was phenomenal. I think I learned more in this last hour than I've learned in the last 6 months on liquid biopsy. So really, thank you for that. I'll call my panel. I'm sure each one of us enjoyed this, but we really need to ruminate on that. I have a lot of slides. I'm not going to use all of them. Can I start with Dr. Biswas, medical oncologist from Calcutta, Dr. Indraneil Ghosh, Dr. Bharat Rangarajan, Dr. Sai Vivek, Dr. Krishna Prasad, Dr. Amrit Kaler, Dr. Chandagowda, and Dr. N.K. Warrior. And of course, Dr. Poppert is there. And I will eventually, Dr. Raja, please, I will ask you questions because I know you're absolutely the guru of precision medicine in India. Okay, so I think Bhuvan very nicely put forward that pyramid that showed what we're really doing in India. Can I start with Dr. Biswas? Dr. Biswas, what do you do in your practice? Sequence together, NGS, and if you do NGS, is it a small panel? Is it hotspot? Is it CGP? It is complementary or some other?
So in my practice, as access is one of the problems. So 80% of my, so majority is definitely NGS. Only few is a sequential. So let's say 80 to 90% will be NGS. And among the NGS, I think 90 or 95% will be hotspot panel. Okay. Only 5% will be CGP. Mostly tissue based. I am using liquid based CGP only in a resistance setting. And upfront, I am doing. If I am doing a CGP, I am doing on practice.
Okay, I think you echo what Bhuvan was saying. This is our most common practice. But let me go over to Dr. Chandagowda because I know he practices in a very different hospital than yourself. Dr. Chandagowda, you're there?
Yeah, I'm there, Dr. Nitesh.
So what would you do? And I'll come to a few more questions in a minute on that.
So definitely I do an NGS. That will be a limited panel in the majority. A broad panel only in some patients. So I also sometimes tend to do a COBAS, whereas EGFR, where you get EGFR in 2 days. So that gives us an information within 2 days that whether the patient has to go on for an oral treatment vis-a-vis a chemotherapy. So that makes the decision faster. In addition, yeah.
You're doing a ALK by IHC and you're sending for NGS.
NGS and an EGFR also. So we can get that EGFR information within 2 days. And then NGS, we can wait for 3 weeks. So that within 2 days, we can make a decision to start either chemo or oral molecules.
I think that's certainly an approach because we often struggle with ALK anyway, and we know that ALK is allowed to be treated, and of course EGFR. Dr. Raja, can I come to you? Because I was very intrigued when Sanjay was speaking about quality parametrics and error rate. I don't know how to ask these questions to my plethora of companies that come and say that please prescribe our company's NGS. This is the cost. This is the range of mutations that we are giving you, and we will make the logistics very easy. I've heard those things, but I don't know the quality questions to ask. I don't even know what error rates actually did. How do you affirm that the company that you're sending to is of any quality at all or not? I mean, forget quality grade 1, 2, 3, 4. We were not trained for this.
I don't know. That's tough clinical situation. But then the best way is to probably stick to one or two of your comfort level and see how it translates in clinical practice. I think within few months, I always say that the proof of the pudding is in eating. Then if I, in my own institution, so 3-4 years ago, when they first gave me the RET, how would I believe that? And I get an access and then do the drug. Similarly, some rare variants. So the point is, what I'm trying to say is we don't have all the answers, but stick to standard options if possible. Cost is an issue. Gold standard is, without naming anything, you would look at FDA standard or FDA accepted one if it's possible. Then you look at, listen to everybody and then pick one or two for cost factor, work with that and see how your clinical, correlation goes and settle down. That's what I can tell you, Dr. Nitish.
That's a very fair point. You're right, the cost is an issue, and you're right that it is more of a clinical experience. So we really don't have a matrix to know what the quality is. What also I heard from Sanjay, and maybe Dr. Ghosh, you can take this, Dr. Anil Ghosh. What I also heard from Sanjay was that the panels were changing partly because new mutations were being discovered, right? So if that is the case, how do we know that the quality parameter? And I will come to the cost in a minute to maybe Bharat. But Indranil, any experience or does this worry you that the quality of the testing may be inadequate?
Yeah, so you have asked a question which I ask to myself on daily basis, and yet I don't have the answer.
Yes. Okay, I'll actually give you my answer in a minute, but I will come to maybe Bharat Bharat in a minute. Bharat,
Yes.
What about the cost of therapy? Let me give you an example. A patient comes, and this is a real example, right? A patient had EGFR and ALK and ROS1 negative on a tissue NGS. It was a local hotspot. Had multiple lines of, or not multiple, had one line of chemotherapy failed, came to me for a second line chemoimmunotherapy, which I started. I took the tissue and the complementary approach here. No, I took only the tissue, in fact. And he had a EGFR deletion 19, which was obviously missed in the first testing. Started on osimertinib, doing very well, but he did a rough calculation. I won't tell you his surname, but you can guess what it would be. But he did a rough calculation. He said the test was 2,70,000 rupees, but the cost of therapy I spent so far is close to 14 lakhs rupees because he was by now on chemoimmunotherapy. And then he said, I've lost 300 days at work, which has also costed me another couple of lakh rupees. Do we really calculate that cost in the outpatient when we compare it to the cost of the right test?
I don't think we look at it from this way. This is a patient perspective of, how much he has lost and, what is the cost for the alternate therapy that he, not alternate means I don't mean non-allopathic therapy, what alternate therapy, alternate to the driver mutation driven therapy. We don't think of it that way, but we do think of it in another way in the cost, in the sense that we were discussing what tests to do and all. When a patient comes to us, to a certain extent, by the time the first 2 visits are over, we know whether this patient is going to afford a second or a third generation TKI, whether the patient will afford a ALK directed or a ROS directed therapy. And most of our patients now, of course, it's a slightly different because immunotherapy has become slightly cheaper, but we know what they can afford. Now, if the patient is never going to afford all these therapies, practical decisions are, they may still afford a first generation TKI. So even for a first generation TKI, I would prefer to do a NGS, maybe from what his pocket will allow, and that may be a 10 mutations or a 12 mutation short lung cancer panel. Although of course Dr. Sanjay Popat very clearly said that he wants a broad one. I understand, but that may not be feasible. Whereas if the patient can actually afford treatment even a bit, then I think what you're saying is right. We must think of all these factors. We must do both tissue and liquid. We should not miss out on mutations, especially because if the patient can afford immunotherapy, we would be giving immunotherapy, which is much more expensive than doing the test.
Yeah, absolutely. And so there's opportunity cost of it's actual cost of giving the wrong therapy, which we know doesn't work, and then there's an opportunity cost of not giving the right therapy as well. And I think you hit the nail on the head. Dr. Sai Vivek, again, I'm coming back to Sanjay's lecture, which really fascinated me. Fixation time. There was a very clear link he was showing of how we can miss RNA-related fusions, even if you've got an RNA-based test at your lab or one of the good labs in India. But fixation time, we really don't have any control on that. And I keep pushing for it, but I don't know how long it takes for the block to be made at my setup. Any inputs into that? Have you thought about this? Is this something that you know that you have already fixed at your setup?
No, sir. I'm still completely awestruck by the lecture we just heard from Professor Popat. I think there's a lot of learning that just happened in the last 1 hour. And I think going to the clinic back on Monday, it's a learning thing for us to inquire more about these things. But one thing is RNA testing, the first part of your question. I did have a couple of patients where they were multiple lines, short panels, and a semi-long panel has missed mutations. And finally, the patient was sent for RNA sequencing, and after 3 years of battling chemo, immuno, an ALK was picked up, and now she's on lorlatinib. So again, that patient could afford it, so she could do it. And now we know with lorlatinib, she's going to have many more years of quality of life. So there's a lot to learn. I'm going to take back and practice from Monday.
And that brings to a case who now I'm thinking may have been just poor tissue, who did all the right things, expensive test. And then on progression, we did a liquid biopsy to look for gain of or targetable mutation, and she had a ROS1. And the question was that maybe it was just not the right fixation and nothing else. I mean, it's the same platform that we're talking about. And so, yes, again, thanks to Dr. Sanjay, we've learned a lot today. But really what I'm hearing is we do profile a lot of patients on hotspot and small panels. Some of us do CGP. Very rarely do we do combinatorial approach together. I'll come to that in the end. We'll show a few cases. But essentially, what we also heard before was that we really need to get down to combination and tissue and liquid. And while I know cost is an issue, but I do also feel that chemoimmunotherapy, while immuno is cheaper in India now, but it's not cheap enough when you put the whole economics into section. And maybe we should all get together. Dr. Raja, I'll present a small write-up to you and think of the economy retrospective of what was the economical loss of patients who were later found to have a target. Maybe we can pinpoint each 2 patients and see what was the economic loss. I have that patient who I think came to 18 lakh rupees or something, but that would be very interesting to see what was the economic loss by spending 2,70,000 or whatever, 3 lakh X thousand or something before versus giving chemotherapy. Okay. What are the challenges with CGP and what is your proportional of not? So that is not really feasible. We've discussed tissue is an issue, how we want it and how it turns out to be. Dr. Raja showed this also, that by the time we really get down to the crux of the matter, what are we dealing with? there's very little tissue because, I mean, no patient reads the book to develop cancer. So we end up scratching our head most of the time. And this was a very clear illustration of the PEN2 study, the large study that demonstrated that tissue genotyping alone may not deliver timely results before first treatment. And 72% patients, 72% patients, treatment had started before CGP results came in. That is what Bhuvan showed in the Indian data. Krishna Prasad, Dr. Krishna Prasad, your take on that.
Yeah, I think at the present moment, I think most of us would not do this. Most of us would send for at least a hotspot assay. And if the patient is pretty much symptomatic, would start with chemotherapy alone. I think that would be the...
I agree with Bhuvan. 72% patients are not symptomatic. And this was Dr. Pathik's own data. You know, this was not, this was Indian data collected together.
And the other issue I would like to just point out is, it is much easier to order a CGP when patient comes back with relapse or patient comes for a second opinion. It's extremely difficult to convince a patient upfront when you see the patient on day 1 or day 2 for a CGP. That's what I have seen, that most of the patients whom I have done a CGP are patients who have relapsed after treatment or who have come for a second opinion before treatment.
Okay, that makes a very strong point, and I completely agree with you. I do end up seeing a lot of second opinions, and maybe that's why it's somewhat easier for me. But if I may probe that a little bit more, what is the biggest difficulty or the biggest challenge? Is it the fact that the cost is prohibitive, or is it the fact that generally as a group we don't believe that it aids anymore? Like the lecture today was very revealing, but before that,
I think it is just the fact that it's a very, very expensive investigation. And it's difficult for the patient and their relatives to really understand why this very, very expensive investigation is required, because their idea would be that the whole treatment would be over within that amount.
Yeah. Okay. I think I agree to that. And of course, there are two populations in India. As I say, India is the country of the richest and the poorest. So for some, it's very easy, and others, it is very difficult. And that is our reality. Do you believe that performing tissue CGP alone, had the cost not been a concern, may miss a few patients? And this is coming down to what Prof. Popat showed, and actually the Nile study very clearly shows that if you do liquid alone or if you do tissue alone, you're actually missing. And I think he showed the study of 25% each miss and 87, 88 when we were talking about doing both together. So if I come maybe to Dr. Warrior, Dr. N.K. Warrior, your views on this, if money was not a concern, would you do both together, or actually you're still convinced that tissue is a must?
If money is not a problem, then I will certainly go for a combination of tissue and blood sample, the circulating DNA. So, but unfortunately, it's very, very difficult to convince the patient. And as Prasad and the previous panelists pointed out very well, it's very easy for us to convince a patient when they come for second opinion or for once they recur or relapse after the primary treatment. But apart from that, if they have an accompanying doctor or a person who is working abroad and all, then probably we can put across them the benefit of doing a CGP, and of course the complete panel with the tissue and liquid. But
I think you're right. What I'm hearing again is that it would be great to have what I was suggesting, some kind of a cost analysis done of the patients where we were missing, how many we were missing, and what happened to them. and that would make even the communication easier. I was actually asking more on the scientific front. We do have a molecular oncologist, Dr. Amrit Keller. Dr. Amrit, you're there. I wanted your views as well of whatever you've seen in practice in India of the combinatorial approach versus tissue alone. I'm not even saying liquid alone because that is done only when the tissue is an issue, and that's logical. I mean, you would do that. Who would not? The question is the combinatorial versus tissue alone.
Yes, thank you, Dr. Nitesh, for this question. It's an excellent question. I manage this laboratory here, and I see. Before that, I would like to say that we do have we do give patients both combinatorial approach. But I have seen that in the tissue, I have seen a lot of problems, like as Dr. Popat was mentioning, that the ischemia time, the fixation time, all these things. And then depending upon the panel which we are using, whether it is an amplicon based or a hybrid capture based. So if it is an amplicon based, there's a chances of false positivity. And if it is a hybrid capture, there's chances of false negativity. So I do believe that tissue does give us a problem which needs to be sorted out. And a combination approach would be a much better approach rather than the only tissue approach. But fortunately or unfortunately, many of the patients, they do not accept or they do not go for such comprehensive genomic profiling. So we do offer a smaller panels in-house. And the smaller panels is again DNA-based RNA mutational panel, which we have it in-house. And that also, again, it has its own limitations. Because if we use RNA-based panel, the fixation time is a problem. And if we do a DNA-based panel, then obviously there's a problem of missing up the fusions. And the mutations, fortunately, is not of a much problem. Then when I look at the different comprehensive scenarios in which panel to choose and which panel to, inculcate in your clinical practice, I would suggest that, we should have a look into the panels which are CLIA accredited or CAP accredited, or the laboratory is NABL accredited, number one. Number two, when you choose a panel, I think looking into the internal validation of the panel is very, very important. Because, the sense...
Amrit, we don't know how to ask these questions. You see, you do. It is same as me putting in you front of 6 family members with lung cancer with a 84-year-old grandfather, and so you know how to ask these questions. None of us were trained. We believe people who speak smarter and think that they're right. We believe people who have a better trustworthy face like myself, and we believe that they're right. So the technology you're talking about, the quality that you and Sanjay spoke about, we can't even remember these details. I have nothing else but to follow you because you say so. And that concerns me. And that's why I said it is easier for me to trust a FDA or a CAP than to actually trust the person across. But yes, your views were valid. Thank you very much. Sanjay, I need to come to you. This is very interesting question on the TAT. So, one second. Yes. This was very interesting discussion you had about TAT, and you spoke briefly about giving chemotherapy and maybe changing the milieu of the tumor in that time.
The problem is you've got to remember that chemotherapy is mutagenic, right? We know that from CHIP data, clonal hematopoiesis data, and other data. As soon as you apply chemotherapy to a tumor, you apply selective advantage and you change the genomics of the tumor. You make it more aggressive, you make it more mutagenic, you will generate mutations in the tumor. So whatever you're doing to the tumor, you are therapeutically changing the tumor with chemotherapy. Is there a real need to do that? I would argue that the vast majority of patients, as you've already said, right, they can wait a week or 10 days to get the results back, right? Why are we spending money and time to give them the chemotherapy? You're changing the biology of what you're doing before you can give virgin territory TKI to a patient. You find that you've started the patient on chemotherapy, worst case scenario, even immunotherapy as well. And then 15 days into it, you find that they're suitable for osimertinib. You've got a myelosuppressed patient, you're going to have to wait. It's just a mess, right? You're much better off with non-mutagenic, non-chemotherapy, virgin territory start. If the patient's symptomatic, of course, you need to start something, right?
Of course.
But in the real world, you can really get away with it.
Yeah. I'll ask you another provocative question there, because it's been on my mind since I was hearing your talk, which is, if you're talking about the quality of test, there is every probability that if the test misses it, you will end up with chemoimmunotherapy. And we have already said at least immunotherapy adds no benefit to patients with EGFR, ALK, and MET, but there have been at least some studies which says it can cause hyperprogression. The patient I was speaking about actually caused hyperprogression, and that's why the whole, that it costed time, money, and I became unwell. How much truth is in that statement?
Well, I think hyperprogression is a definite finding. It tends to occur more with checkpoint inhibitors monotherapy or dual checkpoint inhibitors rather than with chemotherapy. The bigger problem that we have in the lung world is that our TKIs trigger immune tox. And if you're living in a population where there's a high prevalence of genomic alteration where you're going to use a TKI, then you're going to trigger off your immune tox with your TKI. I mean, the classic example is osimertinib, but I'm dealing with a case at the moment where they've been found to be ROS1 positive. We're treating them with entrectinib, and that's actually triggered off autoimmune nephritis from the previous IO that was given because the ROS1 wasn't picked up, right? So you're then in a mess because you're then having to trigger the steroids. It's just totally hopeless. You're much better off from a global viewpoint, spending that more money, getting the comprehensive genomics done up front, rather than the cost of all these problems that later down the line.
We need about 6-7 hours lecture with you, Sanjay. This 1 hour is not going to help. But these are exactly the clinical issues that we face, and sometimes you're scratching your head that what went wrong there. And that's why I was asking that question to you. What I'll do is now, there's a lot of discussion around this, but I'll go to some cases and we'll talk about them, and then we'll come back to a couple of questions I have on the theory about it. So this is the first patient, and I'll start with Dr. Chandragowda again. So this is a 70-year-old gentleman, never smoker, evaluated for cough and anorexia for 2 months, and the PET scan showed about a 4.5 centimeter right upper lobe mass with mediastinal lymphadenopathy, but he also had some adrenal and bony metastasis. He had asymptomatic brain metastasis at diagnosis, which was caught on the MRI, and we did a biopsy of the lung lesion, which shows TTF1 positive. PD-L1 was 50%, and the tissue was insufficient for further molecular testing. In your practice, and I'm not asking for a politically correct answer, Gardant is not serving dinner today. So what would you really do to this patient? Dr. Chandragowda, you there?
Sir, he just left because of some connectivity.
Dr. Bishwas, let me go to you on that. Dr. Bishwas? Okay, next in line, Dr. Indranil Ghosh. Dr. Ghosh?
Yeah, so obviously I would send a liquid biopsy for him, and depending on the symptoms, I may wait for the results.
Virtually asymptomatic. Of course, he had a little bit pain in the back, which was well controlled on a bit of paracetamol and tramadol. Day 5, he came in with a review, and he was reasonably well. extremely nervous daughter who had flown in from US saying, please start chemotherapy immediately because my dad has metastatic stage 4 disease.
No, that is not the issue. We can obviously discuss with the patient and the family and convince them. But if I am convinced that the patient doesn't need immediate chemotherapy, I will send the liquid biopsy and wait.
And the TPS of 50%, I mean, that is very tempting for immuno single agent in a 70-year-old gentleman.
It is very tempting, but as Dr. Popat mentioned, that we will land in a disaster if the patient ultimately turns out to be EGFR positive.
Okay, so this gentleman had 4 cycles of Pembro, pemetrexed, carboplatin till April, maintenance PEM after that, and pembrolizumab with it. Had intracranial progression with leptomeningeal metastasis, as well as progression in the adrenal and the bones, and was switched to paclitaxel in October, which showed stable disease at 3 months. And at that point, Gardant 360 liquid was sent and a MET skipping 14 mutation was seen. Maybe I'll take this to Bharat. Bharat, do you feel this was a gain of mutation, or do you feel that this may have been sitting there from right at the beginning?
This patient, I think most likely, at least there must have been a clone of, this mutation present. Whether the clone was pressured to become the dominant clone because of chemotherapy, or whether, this was always a dominant clone, it's very difficult to say, but I think it must have been there at baseline.
Okay. Anyway, so this patient, as we said, got MET14, and I agree this clone must have been there. We do see that patients who are treated with chemo or immunotherapy and have even a small number clone grow with time and then becomes the prominent clone. He got capmatinib with a PET-CT MRI brain showed partial response. He did well for a couple of months and it continued to improve. And remain well. This is not as of today, but this was about 6 months ago. So he did well for at least about 2 years or 1.5 years since then. That brings to the point, Dr. Sai Vivek, I'll come to you, which we briefly discussed about the quality and everything else. But what we have not discussed is about the low ctDNA inputs, the MSI TMBs. Sanjay spoke about the TMB, it was quite revealing. What about the genomic? What about that the lab we are talking about have already published data in the peer-reviewed journal, so have some validation. Do we really spend enough time doing that now that we have agreed that liquid biopsy is required? And if I may add, is more difficult than tissue biopsy CGP at times?
Yes, sir, but we are not yet there. We haven't arrived, but I think year on year or month on month, we are slowly starting to put these thoughts into practice and then start looking for labs which do have satisfactory results in terms of all the things that we see on the screen. But especially with TMB, now we are all sure that small panels, it's useless to even look for TMB. But I think we will get there sooner, but we are not yet there.
But we have a very interesting situation where we have a tumor agnostic immunotherapy approval for TMB over 10. The approval never said tissue or liquid. We do know liquid is more. Approval never said where would you do the test from. Although there's a companion diagnostic there, but it does not talk about this. How do you address that issue?
I think that again brings us to the factor that when we are looking at especially TMB and certain markers which can vary from lab to lab, wherever possible using FDA approved test. I'm saying it's not possible in every patient, but in whichever patient possible, using that and probably looking at all the factors that you had just put up on the screen, including publications, including their labs being CLIA certified or CAP certified. And again, what Dr. Raja sir said previously, if you're sticking on to one lab, whether we can reproduce their results in one patient and get favorable results, I think all these are complete set of factors we have to take into consideration. As you correctly said, TMB in liquid biopsy will be higher than in tissue, and that again puts us in a lot of soup whether to take it.
But Dr.
Okay.
Nitesh, Dr.
Yeah.
Nitesh, why should we be so worried about TMB in lung cancer? Like it may be important in other cancers where, it may be tissue agnostic. Here we are looking at PDL1, whether there is expression, no expression. In a non-driver mutation, you're going to go with immunotherapy. A TMB may tell you whether, it's going to work or not work. But whatever the TMB, if there is a driver mutation in first line, you're going to go with the driver. And in second line, if there is no driver, you could use the immunotherapy irrespective of TMB. So you could do the TMB lung cancer, but where do you place it actually?
I buy what you're saying. I think you're absolutely spot on.
In other tumors, I agree, but not in lung.
You don't need TMB in lung cancer. But having said that, what we are really not saying is that you need TMB, because these are not tests which are exclusive, right? We are saying if you send a panel, you send a test which is most comprehensive, your probability of getting maximum, because none of these results are helping you to say, if it's A, let me give B, unless it's really a very classical case. You often end up with a kind of a combination of information that you then use as a medical oncologist, as an oncologist, to treat patient. And each of that information is relevant.
I agree.
What I'm
I agree with you.
Two things. A, the quality of that is important, and B, I am not sure yet, and that's what I'm saying, we should work at it. I am unsure whether the cost of test is more or less than the cost that we're spending over patient stage 4 lung cancer's lifetime in making the quality and cost better. I'm not sure. I'm not saying I know that. I'm just questioning.
No, I was not thinking about the cost here when I said that. But I agree that, getting TMB done is definitely going to give us information. And we may be able to put that information to use. Like Dr. Popat said, if there is a TP53, how we are going to factor that in when you're... Similarly, we may factor TMB in a small way. And it's good to know the information. But at this point of time, there are so many other things on which we base our decision in lung cancer. But we will learn how to, sort of fine-tune the TMB information to incorporate that into decision-making. As of now, I am not sure how much decision-making. It is information, it may not be knowledge.
Good point. Well said. Okay.
So if I may add, instead of TMB, could we even like STK11 and keep on good examples where having a large comprehensive panel without driver mutations, it will tell us immunotherapy alone in case of a patient with with PDL1 more than 50%. Could that be considered as a better example?
Can I come back to Sanjay on that? Sanjay, if we had a patient with a PDL1 of 60%, a slightly frail gentleman, and no EGFR TKI on the best panel, and we find SKT11, would you treat him with immunotherapy alone?
Yeah, I think if it's asymptomatic, I think immunotherapy alone is fine, right? There are those that would advocate immuno with chemo. There's those that would advocate PD-1 with CTLA-4. Generally, CTLA-4 I find very toxic, so you've got to be prepared to manage those toxicities and the associated family fallout that they inevitably bring. We'd have no really good prospective data with CTLA-4, right? So there are trials which are recruiting, which may change that over the course of the next 18 months. But at this stage, I think CTLA-4 is one of the great religions like TMB. You either believe in it or at the moment you're waiting for evidence.
Yeah. So I think to answer your question, early information, I say this again, there is a level 1 evidence, we follow that to the T, and then there's a lot of information that sits with us. And when the patient do better than expected or worse, we kind of use that information, and there is no second guessing on that. Let me go to Dr. Krishna Prasad. This is a very interesting case of a 75-year-old female, never smoker, PET scan and brain MRI revealed right lower lobe lung primary, widespread mass, multiple lymph nodes, effusion, lung, liver, adrenal, multiple brain. The pleural fluid confirmed metastatic ALK positive, TTF1 positive adeno by IHC. Krishna, what would you do?
Yeah, I think it would be difficult to get a biopsy unless those supraclavicular nodes are pretty big. If we can, I would biopsy this patient, but start on ALK inhibitor.
Okay, okay. So this patient was started on alectinib 600 mg twice a day. Patient results of response on PET after 2 months revealed a rapid intracranial and extracranial partial response. The imaging after 3 additional months identified extracranial and intracranial progression. So very short 5 months of response. Would you repeat a molecular profiling at this point, Krishna? Yes or no? Tissue liquid. This is a difficult one. What would you do?
Yeah, I think patient might have one of the variants there, ALK mutation, so or might have developed something. I think we need to definitely repeat molecular profiling. I'm not sure which would be better. If I had already done the tissue and I had not found anything different this last time, I would go with the liquid now.
Okay, so patient had both sent. Dr. Raja, I'll ask your views on this. Basically, the liquid showed ALK G120R along with the G1269A and of course a EML ALK4 fusion. And the solid basically showed only fusion. Dr. Raja, your views on this? And the TMB was 15.93.
Yeah, first of all, I would have been worried at the patient age, 70, very unusual age for me to think about ALK. So I would have been on the guard thinking, and then my diagnosis is based on IHC, totally granted. It's actually a level 1 evidence, so we act on it. That's also fine. And I'm not surprised that there was an early progression. That's what I'm trying to get at. And as Krishna pointed out, a CGP was ordered and it has picked up, G1202R. And I mean, this is actually on target mutation. So therefore, we need to look at the drug which can be specific to that. Probably alectinib lorlatinib would have been a better choice if at all. But then again, at this point with the second variant, I don't know. I have to talk to Dr. Sanjay on that. I don't know. I have to look into the data.
So 1269 is sitting here, and it is green by obviously most, but there's no data on brigatinib on that.
Yeah, probably lorlatinib available. I may go for it, but if the patient is symptomatic, you know what? Honestly, I would look at some sort of interim chemotherapy to get a control on the situation.
So my provocative question here was, my guess is if we had done this at baseline, they maybe have in a smaller, maybe less VAF, less amplification clone there. Isn't that what pushes us sometimes to start a therapy, but maybe send at least a liquid sample at that point?
Agreed, liquid sample, but Dr. Popat really taught us, and we have learned often that VAF, the VAF is not the clincher. The tier 1 evidence is enough to act, so that's fine. And I won't be swayed by a low VAF if at all. If I have a real variant that is clearly a level 1 variant, but then maybe with the double mutation and 1202R, I may have opted for lorlatinib. That's the thing that I may have done. So that's what I can tell you at this point.
Okay, I think I do need to close. This patient was started on lorlatinib, received partial response at 3 months and continued to do well. This talks about targeted therapy resistance looked by liquid biopsy. And I think that's where I have in fact used liquid biopsy most. In fact, that's where I have started looking at liquid biopsy first in my life, looking for mutations in lung cancer patients who were failing. My first interesting was a patient on chemoimmunotherapy where I did it only for looking for a mutation or progression or something, and we found a MET, and he had a very good response. So we are seeing this more and more. We are seeing across tumor sites where a change in mutation pattern, a gain and a loss of mutation, is helping us inform us better, and that is helping the treatments to get better. This is clearly MET, which we know is a very common gain with EGFR, also with ALK and other BRAF, but certainly with EGFR. On that note, Sanjay, maybe last words from you. At progression, at least, Dr. Prasad very nicely put that patients often will not accept that on day one. But at progression, at least, what kind of approach would you use? Liquid alone or combination or tissue?
Yeah, I mean, again, you have to think about the scenario, right? If they have small volume pleural, there may not be shedding much, right? So ideally, you want to use both. Start off with liquid. If you find your resistance mechanism on liquid, fine. But if you don't find anything on liquid, then you need tissue. And of course, remember that in TKI resistance, MET amplification is not commonly seen. Now, the algorithms that we have for detecting MET copy number gain may not be so good depending on the quantity of cfDNA that we've got. So actually, they can be challenging on NGS as well, right? So MET is difficult to characterize, right? So, and of course, if you've got small cell and late stage out, they can change to squamous as well. So really ideally both, if feasible.
Yeah. I think the long and short of it is, the more information we have, at least at one point when the patient performance status is still good, I think it helps with giving the treatment. What I'll do is, before I end, I would ask each of my friends to say a closing statement of the day today, and then I'll hand over to Dr. Raja. Dr. Bishwas, you first. Okay, he's not there.
Yeah,
Sorry,
yeah.
There, Dr. Bishwas? No,
No, sir, it's not there.
Dr. Ghosh, Dr. Indranil Ghosh.
Yeah, I think we already had had some idea, but after today's talk of Dr. Popat, we are much more clear, and this discussion also, that we need to focus more on liquid, especially because the tissue is not always available, and the fixation timing and all the proper preservation is not there. So we need to look into liquid biopsy at multiple time points in one patient in the time to come.
Thank you. Dr. Bharat?
What was very simple has become more and more complex. The worry is that this is more of a philosophical comment. The worry is that whenever we are seeing a patient, we don't know what we are missing. We send any report. We send a HND, IHC, NGS, ARMS, PCR, whatever, liquid, solid. The issue is we know what we are getting, but we don't know what we are missing. So, you get a patient with sometimes I still find this, there is a molecular oncologist here. We find a lung cancer patient without any mutation. You send, mostly it's a solid, of course, on the NGS. No mutations detected. This happens. Then, I'm really worried, no mutations, nothing, not even a KRAS, not even a TP53, nothing. Yeah. So has how do I believe this test? So what we are missing, we really don't know. That's going to be one of the toughest challenges that I will face in practice.
Good point. I will just add one thing to that. What was simple was actually very poor PFS OS. What is complicated is actually complicated with making the OS better. So
well said.
On that note, Sai, your last comments, learnings, interesting questions, whatever.
I think there's abundance of learnings. I'm still awestruck, as I was mentioning, and I think this space is getting really exciting for us going forward. And I think I'm looking forward to the next couple of years. I think that's it from my side.
Thank you, Krishna.
Yeah, I think for a few months we had a liquid, CGP followed by a complementary tissue CGP if the liquid biopsy was negative. So I think that would be an ideal scenario for India.
Good point. Good points. Dr. Amrit Kaur and then Dr. Warrior.
Yeah, sorry. I think cancer is a dynamically complex disease and it becomes heterogeneous as it goes. So I believe looking at all the tests, we should incorporate both liquid and solid at the same time in the beginning, and then follow it by follow or monitor the progression by liquid biopsy. Thank you.
Yeah, thank you. Thank you.
Yeah.
Dr. Warrior.
Yeah, I have learned a lot of things from Popper's discussion today. I feel that tissue plus liquid NGS together is going to be the standard of care soon. And at sometimes even the liquid biopsy is going to be the superior to tissue if all the technique is refined. And today, one more thing I have learned from him is to look into the technical errors we all make while sending the samples, and especially when we are not communicating with our staff to how to preserve and how to get it and how to send it at the earliest. So these things I think so we need to learn more about the way people are doing NGS and tissue biopsy processing and other things. Probably the liquid biopsy is going to be the future.
Thank you very much. My last comment before I hand over to Dr. I think I learned a lot. I was very worried when I was listening to Sanjay's talk about the quality. I genuinely, I think I'd known this before, but for the first time I was panicking, thinking, crap, I didn't know any of this. And how was I using some labs? The second thing was, so I am really going to look into this. The second, for the first time, we've always said cost is a concern. For the first time, I'm thinking, how do we sort it out? I don't think just talking about it will sort it out. I do think we'll have to get a head together and we do some kind of analysis to see how much does that cost make a difference, spending in the beginning versus using that opportunity cost of bad treatment and wasting later. With that, over to Dr. Raja. Thank you very much.
Thank you, Dr. Nitesh. Amazing moderation and really touching cases, reality check cases all along. There is no doubt that liquid is solid. I would even say that liquid is gold. Now, liquid gold is valuable, but as a middle class mentality in India, I only wish that the gold prices come down. That's all I can pray. So over to Zydus and Gardant. Thank you so much for this.
Thank you. Thank you.
Thank you. Thank you, all the eminent advisor who we have joined today. Thank you very much. Thank you, Dr. Nitesh, for the lovely moderation. We really enjoyed it. Thank you, Dr. Bhuvan, for the speaker talk, and definitely Dr. Sanjay for educating us. And last but not least, great thanks to Dr. T. Raja for driving this program and giving the expert comment. And really, I'd like to thank Dr. Nisha and Dr. Serene and all the Gardant team for this collaboration, and definitely Rajesh and his team for collaborating with this. Thank you very much. Good night. And the point which you raised in the initial stage, that what we want to learn from it, I definitely, my team along with Dr. Isaac has been able to get the answer of it. Thank you very much. Thank you, Dr. Raja. Thank you, Dr. Thank you. Bye-bye, sir.
Thank you, everyone. Good night.
Good
Thank
night,
you so much, everyone.
Thank
Good night.
you.